All right, welcome everybody. We're going to go ahead and get started. Just to make sure, in the back of the room, wave your hands in the air like you just don't care. Wonderful. All right.
Okay, thanks everyone for attending. It's my great pleasure to welcome you to this session. I'm Leah Resnikoff, and this is co-chair Dr. Jay Freeman. These are our disclosures. And so, as we all know, there's been increasing evidence over the years that CFTR can play a role in other systems outside the pulmonary system, and some of those are just illustrated here. And the goal of this session is to elaborate on some of the findings of these organs that we've already described, but also maybe introduce some additional systems that maybe have gained increasing information about the role of CFTR. So our workshop overview, our goals are to understand the potential cardiac risks, events, and outcomes for individuals with CF, understand the association of CFTR genetic variants and cancer, as well as identify advancements in our knowledge of CFTR function in reproductive tract physiology, kidney function, as well as olfaction. This is the lineup of our speakers. You can see we have sort of a very diverse number of titles here, and the goal will be to have each speaker talk for approximately 15 minutes, followed by a 5 to 6 minute question. So thanks for your attention, and now we'll introduce our first speaker.
Thank you so much. It's my pleasure to invite Dr. Agnes Urban up. She's going to talk to us about how CFTR absence affects the kidney structure and function.
Well, good morning, and I would like to thank the organizers for the opportunity to present our data and talk about kidney health in people with CF. I have no disclosures. The 80-year journey from the initial description of CF by Dorothy Anderson until recent years of treatment for many patients with CF has been associated with the increasing life expectancy in patients from initially months to now over 50 years of age. One of the main remaining questions is how to help people with cystic fibrosis to maintain the healthy and fulfilled life. In order to do that, we need to understand the long-term consequences and extrapulmonary manifestations of CF. Kidney disease, especially chronic kidney disease, is one of those extrapulmonary manifestations which is understudied and not completely understood. The data show that adults with cystic fibrosis have 10 to 20-fold higher risk of end-stage kidney disease relative to the general population. And among those people with CF who have chronic kidney disease, the incidence of renal failure doubles every 10 years of follow-up. The mechanisms of kidney disease are not well understood. It has been historically thought that aminoglycoside exposure as well as episodes of dehydration are responsible for the kidney disease, but newer data indicated about 1/3 of kidney failure cases in people with CF, and that exclude patients with diabetic kidney disease, have no identified cause. Part of the problem is that the conventional test that we use for detecting kidney function or decreased kidney function, serum creatinine, does something like this. There is no direct or direct correlation between the GFR and plasma creatinine, so that leads to majority of patients, and based on the CDC report from 2021, majority of patients not realizing that they have chronic kidney disease until it's very late. So, for example, with normal GFR of approximately 120 ml, serum creatinine of 1 is normal. However, when there is a drop in GFR by 50%, the creatinine is increased only from 1 to 2. So how many patients experience this increase in serum creatinine, whether permanently or transiently, don't realize, and even their physicians don't realize that there is an underlying decrease in kidney function by 50%. At the same time, the clinical symptoms emerge very slowly, and I would argue that many patients and also their physicians don't realize that patient may have chronic kidney disease when the creatinine is just slightly elevated. So let's talk about the homeostatic kidney function. So there are four elements: the glomeruli, renal tubules, and interstitial and vessels. Glomerular are the filtering units, and I want to emphasize how hard they work. They filter about 3 pounds or 1.5 kilograms of sodium chloride and 180 liters of water every day. To do that, the filtered initial filtrate is reabsorbed along the different nephron segments, and the tubules really have to work very hard and very efficiently in order to absorb and finally form about 1.5 liters of urine. So the different segments of the tubules reabsorb and secrete electrolytes, organic compounds, nutrients, regulate acid base and water balance, and excrete urea and other metabolic waste products. So you can imagine that the work of the tubules, especially the proximal tubule that takes the bulk of the work, is extremely hard and has to be very efficient and precise. So the proximal tubule functions at the very high metabolic rate and requires oxidative stress. Is vulnerable to oxidative stress and is the primary site of renal injury. And that involves all kinds of injury, whether it's ischemia, hypoxia, oxidative stress, obstruction, and any kind of injury. The cellular stress that is induced by renal injury leads to cell cycle arrest, and that is actually a protective mechanism. So those cells become senescent, and they are viable, they are metabolically active, but they're unable to proliferate. So those senescent cells start to produce pro-inflammatory cytokines and enzymes. They degrade extracellular matrix. And at this stage, if the stress is moderate or not prolonged, the repair mechanisms can restore the kidney function. However, if the stress goes too long or is severe, that leads to cell death and is followed by tissue damage and loss of kidney function. So it is absolutely critical to recognize kidney disease early and eliminate the cellular stress. So let's think about when we can intervene. So this is really the double-edged arrow in blue indicates the period of time when the cellular stress can be removed and remedied. And if that stress goes too long or is severe, there is a phase where the patients undergo changes in the kidney that are becoming irreversible. So one of the research questions that we asked were whether patients with cystic fibrosis are intrinsically predisposed to kidney disease or whether the renal injury is just induced by extrinsic factors such as dehydration, aminoglycosides, other toxins, any other external stresses. So in order to answer the questions, we used a mouse model, the G542X mouse model that was created and characterized by Craig Hodges in 2018. So there is a reduced CFTR mRNA level in different tissues, including the kidney. There is absent CFTR function, and the mice have typical manifestations of mouse, and that is reduced growth, both longitudinal and weight, and intestinal obstruction leading to decreased survival. So we used kidneys from two different age groups of animals. The young ones were between 6 and 11 weeks of age, and we have 8 animals in the control group, and I will refer to those as the wild type, and 8 in the G542X, which I'll refer to as the knockout. We have 1-to-1 male to female ratio. We also have an older group, which I refer to as aging, between 31 and 38 weeks of age, and we have half the number of animals so far. So there was no difference in the mean age between the knockout and the wild type animals in the younger or the aging group. And we started by examining the body weight of the animals from which we received the kidneys. And as was previously characterized in the young group, there was a decrease in body weight. However, we examined a group that has not been published before in the initial evaluation by Craig Hodges. So the older animals also had decreased weight. Now, we looked at the kidney weight in these animals, and in the younger groups, there was no statistically significant difference in the kidney weight. However, when the mice aged, there was a decrease in the kidney weight. So that suggests that CFTR dysfunction is associated with some progressive loss of kidney weight. So let's just think what might be the reason for the decreased kidney weight. So we have to look again at the histology and development of the kidney. And the proximal tubule is the region where between the young and adult animals, this is the region that grows exponentially, and initially taking approximately 30% of the mass of the kidney, it grows to the point where it takes approximately 70%. Just to give you an example, what is happening with the length of the tubules, the proximal tubule at birth is approximately 2 millimeters, and it grows to 12 millimeters. So that takes the bulk of the kidney. Now, what happens during chronic kidney disease is the reverse. So the proximal tubules also reduce in number, and they, for the reasons that I explained earlier, under the cellular stress, they start become atrophic, and that also leads to the atrophy or hypertrophy of nephrons, so the connection between the glomeruli and the tubules. And the hypertrophy is a compensatory mechanism, but eventually those glomeruli and tubules become atrophic because they cannot sustain the excessive stress. So that leads eventually to crowding of the glomeruli because there is less tissue between them in the cortex. So in the next set of experiments, we just wanted to have the indirect evaluation by measuring the glomerular density. And we used very simple histologic technique with periodic acid shift staining, which showed us the position and the glomeruli. So here I'm showing cross-section of the kidney with the circles in red, just showing where the glomeruli are. And we counted the glomeruli under light microscopy and measured the cortical area by two different kinds of software, and expressed the glomerular density as the number of glomeruli per cortical unit. So what we've seen that already in the young animals, the knockout was showing increased glomerular density, and that also persisted in the older animals. You can see that the number of slices per kidney were different. We are still continuing to add data here, but we already have statistically significant differences. So that suggests that CFTR dysfunction is associated with glomerular crowding in both age groups. In order to look more carefully at the proximal tubule, I want to introduce to one more concept, and this is the glomerulotubular junction, or GTJ. This is a transition zone between the glomerular pole and the proximal tubule. So basically, this is a tall columnar epithelium that is extending from the glomerulus to the proximal tubule. And after injury, that tall columnar epithelium becomes squamous. So the transition from the columnar to squamous epithelium is associated or indicates that there is a cellular stress, and that follows with autophagy, overexpression of TGF-beta in the proximal tubule, which has very big significance in the kidney because it leads to fibrosis. And actually this zone, the GTJ, is the initial zone where the renal fibrosis starts and propagates more distally. So there is a very simple and relatively old technique to evaluate the health of the junctions. It is based on the fact that the columnar epithelium of the healthy junctions takes the lotus lectin and it stains it. So here is the cross-section of a kidney with the green circles showing the cells in the proximal tubule that are taking up the lotus lectin, and the red, those that do not. And those that do not are the squamous epithelial cells, so that gives an impression of sort of disconnected glomeruli. And I'm showing this more carefully here. So again, in the green, you can see that the lotus positive cells or glomeruli have cells that take up lotus, so it gives the impression of this nice connection between the proximal tubule and the glomerulus, and it looks like the glomerulus is connected. On the left, with the red circle, there is no lotus lectin, so this is the lotus negative or injured or squamous epithelium, and it gives the impression of a tubular glomerulus. In fact, there is no decapitation of the glomeruli. It is just that we are not detecting the cells because they are squamous, so we cannot see them. So let's see what we found. In the young group, when you look at the wild type in green, there is majority of the glomeruli which are lotus positive and some that are not lotus negative, and that's normal. About 10 to 20% of the glomeruli in normal healthy kidney show this distribution. But when you look at the knockout, there is an increased proportion of the lotus negative glomeruli, and that gets much worse with the aging. And in that situation, we have almost 1-to-1 ratio of the lotus positive and lotus negative glomeruli. So I touched the wrong direction. So that indicates that CFTR dysfunction is associated with progressive injury to the junction and the proximal tubule. So in summary, the CFTR dysfunction leads to progressive renal changes at baseline that are detected by the decrease in kidney weight. CFTR dysfunction is associated with changes in the tubular interstitial compartment, most likely the dropout of the proximal tubules, which is supported by the glomerular crowding and the higher proportion of the injured junctions. Now, this is very preliminary, and our ongoing studies focus on measuring the glomerular volume. So we want to detect whether there are atrophic or hypertrophic glomeruli, but that takes a little more time and different techniques. We're also looking at the expression of tubular injury markers, presence of fibrosis, and also very direct quantification of the renal tubular cell populations, and specifically trying to measure the proportion of cells in the proximal tubular cells. But even with this preliminary data, I think there is a high suspicion that people with CF may be intrinsically predisposed to kidney disease. So I would like to end by acknowledging everybody who contributed to this project, and specifically I want to mention Mateusz, my graduate student, who is responsible for generating the data. He's actually presenting the same data at the American Society of Nephrology meeting right now, happening unfortunately at the same time. So I'm presenting on his behalf. I want to give a big shout out to Craig Hodges for generating this beautiful model that we can use, and also excellent collaborators who are working on different aspects of the kidney function in people with CF together with me. And this is both group from UVA, Dartmouth, and UAB. So thank you.
Wonderful talk. We have time for a couple questions. I know we have some people in the overflow on the outside. They're welcome to come in and ask, or give us your questions on the app. Either way is fine. Do we have any online?
I can start. So I noticed that when you looked at glomeruli density in your aged population, it appeared to have almost two groups. Was that a sex effect, or is there something else going on?
Yes. So thank you. This is really a great observation. So we did not have enough data to separate, as you've seen, we used males and females. The different distribution is actually between the males and females. And the pattern seems to be the same, but the lower numbers are coming from the females, higher from the males. So once we acquire enough data, we'll be able to show them separately.
Okay. Thank you, Agnes, for your nice presentation. Thank you also for getting to know you here. I could not refrain from adding something to this issue on the kidney, because CFTR is actually expressed in the kidney, as you know, and presented. But it's also expressed in the collecting duct. You focus on the proximal tubule, and the collecting duct, it mediates in the beta integrate cells bicarbonate secretion, like in the pancreatic duct, with the exact mechanism, it's secretin activated, and CF patients cannot activate this and therefore have metabolic alkalosis. And there's a series of papers from our lab has worked that up. It's a very, very, very prominent phenotype. I just want to add to the discussion that there's something interesting happening in the kidney also in terms of normal physiology, which is altered. And for the interested people, you can read the papers.
Yeah, thank you for the comment. This is absolutely essential, and I think we're. Again, my talk was focusing on just the gross morphological changes that we are seeing, but we actually are sharing space and posters 257 and 258. So obviously everybody can come and visit us. I don't know if there's another session at the poster, but yes, this is really, really important point. I mean, CFTR is expressed in different nephron segments, and it's definitely under-recognized. And I think now this is the time to study and pay more attention to the kidney function as well as the CFTR effects in the kidney.
So we have one question online. Are there any plans to look at effective carrier status, and could that be important for prediction of renal disease in large populations outside CF?
Yeah, so we don't know. Obviously, this is just the first attempt, and we are looking at this one particular model that allows us to study just the baseline, but we plan to extend these studies to other models. And also the question about carrier status, I think that's very important.
We'll do one more question quickly, if you don't mind.
Hi, Catherine Cutney from Case Western. I apologize if you covered this, but I'm Peds Endo, and so we're seeing a lot more patients with CF-related diabetes living longer. I wonder if you have any interest in looking at how adding diabetes to this model would impact the kidney phenotype.
Yes, definitely, and that extends probably to just the general effect, not only with CF, but probably similar mechanisms. But what I wanted to emphasize is that even when we exclude patients who have kidney disease due to diabetes, there's still about a third of those patients who have kidney disease for unknown reasons. But that's a good point.
Excellent. Thank you, Dr. Urban. Next, we're going to turn it over to Dr. Freddie Frost, who's joining us from Liverpool and is going to talk to us about defining cardiac risk events and outcomes in people with CF.
Hi, my name is Freddie Frost. I'm a respiratory clinical lecturer from Liverpool. Thank you to the organisers for inviting me to talk. These are my disclosures. I think my biggest disclosure is that I'm not a cardiologist. I'm a respiratory doctor, so this is as new to me as it is to everybody else. But I'll start by showing what happens if you look on Google Images at cystic fibrosis, and you'll see you get lots of nice images of the lungs, the pancreas, bit of mucus there. Skin even gets a mention somewhere on there, but conveniently all the hearts have been explanted from these people. But risk factors for cardiovascular disease have been well documented, have been prevalent in the CF population for many years. Adults with CF have extremely high prevalence of diabetes. People have had to be on high salt, high fat diets for a long time. And chronic inflammation, which is extremely important for cardiovascular disease outcomes in other conditions, such as rheumatoid arthritis, HIV, and lupus, has been present for many years in people as they reach adulthood. But cardiovascular disease hasn't necessarily been seen that frequently within our clinics, and it's thought that that's due to a balancing act by so-called protective factors. So people generally, historically, have had lower BMIs, systolic blood pressures have tended to be on the low side, absorption of cholesterol and fats has been low, and life expectancy has been short, so the exposure to those risk factors over many years hasn't precipitated cardiovascular events. But things have been changing sort of gradually, and they were changing before the advent of modulator therapy, but do seem to have sped up since. So increasing case reports of major adverse cardiovascular events, the first case series of coronary artery disease in CF, and Jamie Ducker's work in Cardiff looking at heart age in CF, showing it's considerably higher than the general population. And why is that? Well, as I said, some of those things have been changing since before modulators, but sort of BMIs have been gradually increasing, life expectancy has been gradually increasing for many years. But things like blood pressure and cholesterol, the changes seem to have accelerated since modulator therapy has been widely available. So the aim of our study was to try and understand a bit about the cardiovascular disease prevalence in people living with cystic fibrosis, what the outcomes were of those diseases and how those outcomes compared to the general population, but also other conditions as well. So to do that, we did a retrospective cohort study in the UK CF registry and also Trinetics. We looked at the time period 2016 to 2020. 2020 was the most recent data set we could get from the UK CF registry at the time. And so you'll see that's largely before the widespread availability of modulator therapy in the UK population. The UK CF registry has excellent coverage of of our population, over 11,000 people with CF annualized data input rather than counter-based data input. But there has been some cardiovascular disease outcome monitoring since 2016. Trinetics is a slightly different data set. This is a federated network of electronic healthcare record data. It includes data on over 50 million patients, predominantly in North America, but does expand, is slowly expanding. And it provides a secure research environment where you can conduct some analyses in the populations that you identify within it. It's an ICD-10 based coding sort of data set. And generally, it seems that if your hospital has a certain electronic healthcare record, then Trinetics will work with those hospitals where they have validated algorithms for extracting coding data and putting it into big databases. So when we looked at the adults in the two cohorts, these were the characteristics. So you can see the average age was approximately 30, BMIs between 23 and 24, generally low rates of things like hypertension, so 2.2% in the UK CF registry and 7% in Trinetics. For reference, the prevalence of hypertension in the adult population in the UK, the general population, is between 20 and 25%, so considerably lower. Low rates of obesity. So the outcomes that we were interested in were major adverse cardiac events, or MACE. This is something that is commonly used within cardiovascular research, but even though it's a term that you'll see dotted around everywhere in each study, MACEs means slightly different things. So for the purpose of this study, we included acute myocardial infarction. We specified left-sided heart failure, as we didn't want to pick up right-sided heart failure from severe disease. And we looked at arrhythmias, including atrial fibrillation. So the first thing was just to define the incidence and the prevalence across the two data sets. And you can see that the annual incidence range in the CF registry was between 0.1 and 0.8%, a little bit higher in the Trinetics data set, 0.8 to 2.6%. I think the differences probably represent the fact that it's likely under-recorded in the UK CF registry, whereas Trinetics is probably more well-suited to sort of cardiovascular outcomes. Next, we wanted to look and see who was actually at risk of MACE. So we looked at the Trinetics data set first. You'll see that the classic cardiac risk factors are all significantly higher in the group that experienced a major adverse cardiovascular event. So they tend to be older. They tended to have higher BMIs, and they had higher rates of diabetes, chronic kidney disease, and hypertension. Similar picture was seen in the UK CF registry, so higher age, higher proportion of patients having diabetes and hypertension. But the UK CF registry also allows you to look at some more disease-specific risk factors as well. And so you can see that there are differences in lung function and IV antibiotic use as well. So next we want to try and think about how the risk in the CF population compared to the general population. So for this, in the UK CF registry, there's obviously no general population comparators, so the subsequent analyses are all performed within Trinetics. So once we defined our CF cohort and defined a general population cohort, we were able to match for similar characteristics. But within the general population, we were also able to identify cohorts of people who live with those other conditions, so lupus, rheumatoid arthritis, and HIV, that are considered to be high risk for cardiovascular disease. To make comparisons between these quite heterogeneous groups, we match them. So match them for the number of analyses. The ones that I'll show you here are the matching for the classic cardiac risk factors. And these are our results. So this is our main analysis, and you'll see in the top right here, this is CF versus the general population. You can see that the CF population had a significantly higher risk of major adverse cardiovascular events, so has a ratio of 1.65. Fairly consistent effects of myocardial infarction and atrial fibrillation, but on the adjusted analysis, there was no difference in left-sided heart failure. When we compared against the other high-risk conditions, so rheumatoid, lupus, and HIV, you can see that in the adjusted analysis, in the blue bars there, that the risk of major adverse cardiovascular events was equivalent, or in the case of rheumatoid, slightly higher. Now, you'll also see that the differences between the adjusted and the unadjusted bars, if I just go back here, between these two analyses is quite different. So we looked into that. It seems to mainly be driven by different age and blood pressure between, or prevalence of hypertension between people living with CF and these other inflammatory conditions. So there are a number of limitations to consider for these type of studies. Clearly, Trinetics is not designed for specific cystic fibrosis research. ICD-10 codes are not particularly well validated in cystic fibrosis. And the CF registry is certainly not optimized for cardiovascular disease outcome monitoring either. There's also this issue with Trinetics about incomplete geographical follow-up, which might be a particular issue for cystic fibrosis. So, for example, if your institution, you are a CF centre and your institution contributes data to Trinetics, but your patient lives 2 or 3 hours away, and when they have their heart attack or their stroke or their ventricular arrhythmia, they go to their local centre, that wouldn't necessarily be picked up in Trinetics. So you really need territory-wide or region-wide sort of data sets to prospectively validate these findings. So to conclude, we found that annual incidence was roughly between 1 and 2% for major adverse cardiovascular events. It seems that our data suggests the risk could be higher than that in the non-CF general population and equivalent to other high-risk conditions. We need efforts to try and characterize cardiovascular disease risk in the modulator era. We probably need to design longitudinal studies that incorporate both lung function, both cystic fibrosis specific metrics and cardiovascular metrics as well, to try and understand what the risk will look like for the population as we move forwards. So I'd like to thank my collaborators at Liverpool Heart and Chest Hospital, LCCS and University of Liverpool. Also like to thank Cystic Fibrosis Trust for the registry data and for the people with CF in the UK who contribute their data to it. So thank you very much. I'm happy to take questions.
Wonderful. Thank you, Dr. Frost. Have a question coming? It's all right. We got time. We're good.
Thank you for a lovely talk. And I think this is a real challenge that we're facing now. And I'm wondering what you're planning to do in terms of how we should be screening patients for cardiac disease, and should we be altering our annual reviews that we do every year to start looking for these conditions?
I think there's 2 ways of thinking about that. There's one, the annual review data is obviously incredibly useful for the registry as well. So I think we do need to alter the annual review data to make sure that we're capturing the basics of cardiovascular disease. So blood pressure, whether people are what their blood pressure is, whether they're being treated for it, are we checking cholesterols, things like that. I think that's one will be useful as we move into sort of chronic disease management sort of situation in CF, but will also then allow slightly more in-depth and more accurate research to be done over the next 5 years as those change. So, yeah.
Thank you very much for your nice presentation. In our Danish cohort we studied, who were treated with ETI, you could see that their salt wasting phenotype, which we describe as pseudobarter, is actually corrected, which you can see in all kinds of parameters, aldosterone, blood pressure, heart rate, and so forth. So they will get a higher blood pressure from now on, those who are on treatment. That should be another aspect of concern in the perspective of the cardiovascular disease risk.
Yes, and it's interesting to consider that if we do check the blood pressure in clinic and we see a blood pressure of 125 systolic, then we might think that's very good. But if someone's lived 30 to 40 years and their kidneys have become very used to dealing with a blood pressure of 90 systolic, then actually that change might be important. And I don't think we know the answer to that, but it's certainly something we have to keep an eye on.
Okay, gotcha, good. Please go ahead.
Freddie, can I ask you about diabetes in here? Because the cardiovascular risk with type 1 diabetes versus type 2 diabetes, why does cystic fibrosis diabetes fit?
It appears to be a risk factor from the data that we've got, but these analyses are quite crude. My impression and experience of seeing the sort of CGM data from our cystic fibrosis cohort is that they spend a lot higher times in pretty high glycemic times compared to type 2 diabetes. So I would imagine that it's going to be in the type 2 diabetes rather than type 1 diabetes sort of end.
Hi, very nice talk. I had a question regarding hypertension. So you mentioned that the prevalence was about 1 to 2%. And I was wondering, like, from what I know, in the pulmonary circulation, there's actually hypertension. It's more prevalent. So can you speculate for why that happens in the lungs, but not in the systemic circulation?
I think it might be back to the previous question's point about the salt losses, and that people tend to have historically have had lower systolic blood pressures because of that.
Great talk. I want to just add one comment. So in the single cell RNA-seq that we did in the mouse model, the same one that I presented, we also see an upregulation of the angiotensin 1 receptor 2 and some features with other transporters that may actually indicate some baseline predisposition for hypertension, which again, it will be very difficult to dissect in a human because of so many variables, but I think seeing that change from really at baseline in the mouse model is worth following. So this is actually something that may complement the information that you were presenting.
Yeah, that's really interesting. Yeah, I think as alongside these epidemiology sort of work, we absolutely need sort of detailed studies of blood pressure, arterial wall stiffness, vascular health, to try and understand what the risk can look like in the future.
So I'm going to ask a little bit of a follow-up question built off sort of what's already been asked. In my liver hat, I preach that cutoffs are probably not the answer. It's trends over time. And I think that's what I'm hearing from the physiologist in the room. So can you comment, do you agree with that assessment and any further comment on that?
Yeah, I think I do agree. To answer the question is, are they cutoffs or is it trends over time? Then we need sort of well-characterized longitudinal studies, and whether that's going to be registry-based studies with linked primary care data, or whether sort of de novo studies that we design and follow up people specifically, I don't know. But those are sort of studies that we need to answer that question.
All right, wonderful. Thank you so much. Appreciate it.
Thank you.
All righty. Thank you so much. Next, we're going to turn it over to Dr. Emma Tillman from Indiana University, who's going to be talking to us about CFTR genetic variants and the association with cancer.
Perfect. Thank you for the introduction.
May have to use the mouse for the
Okay. There we go. All right. So I have no disclosures for conflict of interest, but this project was funded by an internal cancer prevention and control grant through our cancer center. So as we're all well aware of, widespread use of CFTR modulator therapy has resulted in a dramatic increase in life expectancy of persons with cystic fibrosis. Also, in the past few years, we've seen an increase in number of pregnancies. From 2011, we were seeing about 200 to 300 pregnancies per year, and then that dramatically increased from 2019 up to 2021, where we more than doubled, going from 309 to 675 pregnancies in 2021. So historically, having a single CFTR variant or carrier status has been thought to be relatively benign. Data are now emerging that dysfunction in CFTR in persons with CF or carriers with a single CFTR mutation may have an increased risk of cancer. This is supported by some preclinical data showing that downregulation of CFTR production in animals and in vitro models is associated with an increase in carcinogenesis. So the rationale for the study is that now that persons with CF are living longer and that they're now having more children, there may be cancer risk is becoming more of an important healthcare concern. So the aim of the study was to determine the frequency of pathogenic CFTR variants in patients with cancer. So in order to do this, we used the Indiana University Adult Precision Genomics database. So the Adult Precision Genomics Clinic sees patients clinically that have advanced cancers or that have failed initial cancer chemotherapy, and they sequence them in order to find drug targets that would have drug targets for future therapies. In this database, it includes germline sequencing data from 2,422 solid tumor patients from 2015 to 2023. We queried the database for subjects having CFTR gene variants determined to be pathogenic per the CFTR2 database. Then we divided them into cancer types: breast, head and neck, endocrine, musculoskeletal, gastrointestinal, neurologic, genitourinary, respiratory and thoracic, gynecologic, skin, or cancer of unknown primary. The pathogenic variants observed in our cohort were then compared to published population minor allele frequencies using the allele frequency aggregator, or ALPHA, and then scaled to population, to our APG population. And if you're not familiar with these genetics, the ALPHA, this is done with genetics for minor allele frequencies for many different genes, and then looked at per race and ethnicity, and then we could scale this using our patient cohort population. So we had total sequencing genomic data from 2,422 patients. We excluded 355 because they were missing clinical data. Then we had a total of 2,067 with total diagnostic data. Out of those, 95.7% had no pathogenic CFTR mutations, yet 88 persons had, or 4.3%, had CFTR mutations. And this included 87 with a single CFTR variant, and then one person who was homozygous for the F508del. Our cohort was pretty much 50% male-female. We were 91% white European ancestry, 7.4% Black, 1.6% Asian, 0.2% of the encompass the American Indian, Alaskan, and Hawaiian Native. 4 persons reported multiple races, and then we had 3.6% that was race was unreported. The mean age of our cohort cancer diagnosis was 57.6 years. So I'm going to take a little time to orient you to this figure. So along the x-axis, you see the specific cancer types, and then there's a double y-axis. So in the primary y-axis, this is shaded in the blue filled-in bars with the smaller numbers, so starting 0 to 30. And this is the variant, CFTR variant in our cohort. And then outlined in the blue, the dark blue lines, this is showing the total in the cohort for each of the cancer types. So if I just walk you through, on the digestive or gastrointestinal, you see we had 600 total patients in our cohort with a gastrointestinal cancer, and then 27 of those had CFTR variants. So you can see that the number of CFTR variants were reflective of the numbers in our cohort. This figure is showing on the x-axis the number of CFTR variants, and then we're showing the variants that we're seeing on the y-axis. This is comparing the total predicted and those total observed. So the yellow bar is the observed in our APG cohort, and the total expected is that what we calculated based on the alpha scaled to our patient population. 19 unique pathogenic CFTR variants were present in this cohort, and the most common was the F508del, which was observed in accounting for 60% of all the variants, pathogenic variants in the cohort. The remaining 40% of the cohort included 18 unique variants. So in summary, the highest number of pathogenic CFTR variants were found in persons with GI cancers, but this was reflective to our cohort. Based on the minor allele frequencies from alpha, we expected to see approximately 38 persons with CFTR pathogenic variants in our APG cohort. yet pathogenic variants were present in 88 persons within our cohort. So there's definitely some study limitations. Our study was limited by a cancer-only cohort and an advanced cancer cohort at that. Expected population allele frequencies for pathogenic CFTR variants can be difficult to estimate, and these reported frequencies vary greatly between alpha and between nomad. So future studies are planned using the UK Biobank and all of us to compare the prevalence of CFTR pathogenic variants in both a cancer and a non-cancer cohort, and then also to exclude for other known cancer genes that may be driving this. So in conclusion, the prevalence of CFTR variants in persons with solid tumor was over 2 times higher than what we expected. Persons who were carriers of CFTR mutations may have an increased risk of cancer. And as CFTR modulator therapies restore CFTR function and continue to increase life expectancy and pregnancies, cancer prevention strategies may be needed to consider long-term morbidity and mortality in persons with CF and carrier status. So at that time, I can take any questions.
Go ahead.
Hi, Viral from MGH. Great, very interesting work. I know this is supposed to be outside the lung, but I may ask you a lung question if that's okay.
Only one. No, I'm kidding.
So there's some work here at this conference that suggested that there's increased squamous metaplasia in CF. Have you seen any increases in squamous cancers in your populations or in your study?
You know, I haven't looked at this, and like full disclosure, I'm a pharmacologist, so I do mostly like pharmacogenomics and genetics kind of things. So physiology is not my my specialty, but that's a great suggestion for us to look at. And I think if we're using these larger databases of all of us and the UK Biobank, you know, all of them have limitations, but we can get a little more granular where, you know, 2,000 patients sounds, you know, like an okay sample size, but not for these genetic studies. So thank you.
Yeah, it'd be very interesting. So
Yeah.
thanks so much. Appreciate it.
Hello, great presentation. Mina Hanna from Tulane. I was just curious, do you think that there's could be a link between the CFTR mutations and cancer, or do you think this could be more of an inflammatory environment that's prone to recurrent infections that's leading to cancer?
Yeah, and that was our thought for dividing these out. You know, are we seeing more cancers in those areas that are specifically more areas of inflammation and problems in CF? So we were thinking, you know, the GI, the respiratory, are we seeing more cancers in those areas compared to other areas? But even, you know, the work that you're doing in the kidney, you know, very interesting to look. And so that's something we want to continue to sort out. You know, is their target organ, target cancers, and the inflammation is a very big piece in all of this. So thank you.
Thank you.
Hi, good talk. I was just wondering if you see a increase in chemo resistance to those patients with the CFTR mutation, or if they have more metastases?
Yeah, I think our cohort is not a good one for that because most of them are all resistant to. They went to the APG or this. They had sequencing done because they failed first-line therapy, or they had very advanced disease and they're looking for a drug target. But some of these other databases that include cancer and non-cancer, those are great questions that we can look at.
Thanks.
So I have a quick question. We're getting a little better at understanding health disparities and inequality in cystic fibrosis, and the cancer community has been way ahead of most of everybody in that area. We know that roughly 25% of African Americans and Hispanic patients have mutations that are not eligible for current ETI and other therapies. So have you looked to see if there's any predominance in those mutations in these cancers that you're seeing, or is there plans to do any of that type of work?
Yes, that's a very good question. Actually, we in doing this, we found one mutation that was cited as potentially pathogenic in one of the databases, and we saw really high numbers, and we were like, I don't know if this is real. And if you looked at our initial abstract and then like my presentation here, we kind of modified because they're like, I don't know if that's real. We should maybe throw that out because it's one that's, you know, a variant that there's only one reported case of a person actually presenting with classic CF that has one of this mutation. I can't remember what the numbers right off the top of my head, but it's very interesting. And I think we just didn't have confidence in reporting, is this real or is this, you know, a variant that was that was not pathogenic. So I think that's a great question. And I think right now our cohort is too small, but in a larger cohort, I think that's a good thing.
Emma, I also have a question, sort of as a add-on to the variant question. It looked like the largest number of incidents of cancer was associated with the Delta F508. And do you believe that's because it is the most common in CF, or is that telling us something about the role of CFTR in cancer risk?
Yeah, I think it's maybe a little of both. And I think we were really surprised that, it accounted for 60% in our cohort, but there was 40% that were non-F508. So, I think those are a lot of there's a lot of fun things to tease out in a bigger database. So thank you for all those questions.
All right, excellent. Thank you so much. All right, next we're going to have Dr. Daniel Beswick, who is from UCLA, and he's going to be talking to us about the basically the impact of highly effective modulators on olfactory dysfunction.
Thank you. Thanks so much for the opportunity to present, and to the moderators for having us. My name is Dan. I'm a rhinologist and ENT at UCLA. I'm presenting work on behalf of our group, and thanks to the many people who made this possible, including several of whom who are here today, Alex and Jessa, and perhaps others. So thank you very much. What I'll do is I'll talk a little bit about the background of sinusitis and olfactory loss and changes in those areas in people with CF with highly effective modulator therapy. These are my disclosures. So as we all know, CF is a multi-organ process. We just heard several great talks about different organ systems that extends from the pulmonary and GI circuits to the upper airway, including the sinus region and the olfactory center. With improving treatments and extending lifespans, understanding or better understanding outcomes beyond pulmonary status is critical for people with CF. People with CF have also identified that sinus disease or chronic rhinosinusitis and olfactory loss or sense of smell or loss of sense of smell are important issues for these folks. Chronic rhinosinusitis is typically comprised of long-standing symptoms, so chronic disease for many months, with evidence of inflammation on either imaging or nasal endoscopy, with healthy sinuses shown in the upper CT scan and inflammation in the sinuses shown in the bottom coronal CT scan. Data from the registry demonstrates that sinus disease and sinus symptoms are prevalent in people with CF. So when queried, over half of adults with CF identify that they have sinus symptoms. From cross-sectional studies, we know that about 2/3 of people with CF have nasal polyps, and about nearly 100% if everyone underwent CT scan has some inflammation in their sinuses. Sinus disease causes a variety of negative issues. So this causes symptoms, nasal obstruction, nasal congestion, pain and pressure on your face. It can worsen lower airway status. It can serve as a bacterial reservoir and potentially seed the lower airways, which has specific implications in the lung transplant population. Sinusitis also leads to loss of productivity. It's associated with olfactory loss or loss of sense of smell, and it can require additional treatments, either topical therapies such as sinus rinses, additional antibiotics, which may have detrimental effects, or even in certain people, sinus surgery. So there are some significant both symptoms and sequelae of sinusitis. There are different methods to assess how severe sinus disease is. So one commonly used metric is to look at patient symptoms, and there are different outcome measures for that, such as the SNOT-22 questionnaire. We'll dive into this shortly, but there are different ways to look at radiologic findings or sinus CT extent of sinusitis, and we can also use nasal endoscopy to visually inspect the nasal cavity. So I'll focus on the radiologic findings, talk about a technique that we use, and then get into our study. So typically someone who has sinusitis, at least an adult, will get a CT scan, and often these are scored by a human interpreter where we look at the sinuses and sort of semi-quantitatively identify how much inflammation are in the sinuses. Working with Steve Humphreys, radiologist or imaging scientist at National Jewish and his group, his team has been able to help identify and create this machine learning algorithm which precisely segments the sinuses and can quantify pretty quickly how much inflammation is there. So essentially you feed a coronal CT scan of the sinuses through this algorithm. It can identify what percentage is the sinuses, which is shown in the middle image, and then it can generate a 3D rendering of the sinus region. We can then apply different thresholds based on Hounsfield units to determine what percentage of the sinus is filled with air versus soft tissue density, and this helps generate a sort of very precise, reproducible, and quantifiable amount of opacification in the sinuses. Essentially, how bad or good is one sinusitis? This correlates pretty well with Lund-Mackay score and data that we've previously published. So getting into our study, and everybody's familiar with the major and impressive improvements in ppFEV1 and lung function with Trikafta, we wanted to assess the impact of ETI on sinus disease, olfactory loss, and different measures such as health state utility using various validated outcome measures. Our first aim explored quantitative sinus CT changes. Our second aim looked at different patient-reported outcome measures, olfaction and health utility value. And then we have an exploratory aim that Dr. Vlader led, looking at nasal airway epithelial cell function and gene expression. So we did some preliminary data which essentially showed that the machine learning technology worked to evaluate longitudinal changes over time, and it was precise and reproducible. So we conducted a prospective observational study. Adults with CF who were either FF or F minimal function were enrolled before they started ETI starting in 2019. We obtained outcome measures at baseline and then 2 primary follow-up points at 6 months and at 24 months after ETI. There were additional interval remote measures where we collected surveys over the phone and remotely. The primary outcome, again, was change in sinus CT score using the machine learning analysis. Secondary outcomes included changes in quality of life and gene expression and olfaction. And then there's a schematic of the enrollment. So 30 people initially enrolled and provided baseline data. 28 completed 6-month follow-up and 26 completed 2-year follow-up. Some of the initial demographic data are shown there. So the mean age is around 34 years. 60% were homozygous for F508, and the cohort overall had moderate pulmonary disease with a mean ppFEV1 of around 67%. Interestingly, over the 2-year course of the study, non-modulator medication use was stable or decreased. We thought this was interesting because it suggests that a lot of the effects that we're seeing were probably due to ETI, as many of these other medications were either stable or the ones that are boxed in red, the prevalence of use of those medications decreased over time. So first I'll describe the 6-month findings and then go into the 2-year, and at the end I'll talk about the olfactory portion. So in general, after 6 months of ETI, sinus CT opacification improved substantially. There was a mean decrease for the cohort of 23% approximately, and that was significant. The improvement in sinus CT opacification was not impacted by factors such as underlying genotype, prior modulator use, or history of sinus surgery. The spaghetti plot at the bottom demonstrates improvement or change over time from baseline to approximately 6 months for each individual, and the images on the right are a representative example for axial, sagittal, and then 2 coronal sections of improvement visually in the CT scan opacification. So moving on to sort of quality of life. We know that Trikafta improves sinonasal quality of life. To look at this, we use the SNOT-22, which is sort of a cute name for a validated outcome measure that assesses sinonasal disease severity. This test is recommended by the CFF to assess the severity of sinonasal symptoms in adults and older adolescents. So in our study, the mean improvement after starting Trikafta was 15.3 points. The minimal clinically important difference for this outcome measure is 9 points. So this was a clinically relevant or clinically meaningful improvement that occurred by about 1 month and persists for multiple months. Similar to the CT scan opacification findings, improvement in sinonasal symptoms was not impacted by modulator use history, genotype, or prior sinus surgery. For nerdy rhinologists like me, you can break this SNOT-22 down into different subdomains which comprise different symptom areas. So there's a rhinologic domain, there's a domain about sort of ear issues, there's actually a psychological domain, and so improvement occurred in all those domains. We also looked at health utility value. So the SNOT-22 measures disease-specific or sinus-specific symptoms. Health utility value is a disease-independent measure of quality of life. It ranges from 0% representing someone who is dead to 100% representing someone who's in perfect health. The health utility value is, again, disease-independent, so it's not specific to sinusitis, but it can be used in any disease process. And there was a clinically relevant improvement after initiation of Trikafta for our cohort in this measure as well that was not impacted by any underlying covariates. We also sort of looked at productivity loss. So the total cost of disease, as we know, are a sum of the direct costs and the indirect costs, and indirect costs are also known as productivity loss. So chronic disease has significant adverse impacts in absenteeism, so missing work or school, or presenteeism, meaning when you are present, you don't work at a high, your highest function, or impaired activity. So we assessed this using a specified validated outcome measure, and ETI was associated with improvements in multiple measures of productivity loss over time. So these are sort of the 6-month findings. And then we're excited recently to show that the 2-year outcomes, we sort of followed this cohort through 2 years, had continued improvements. So this, again, is an example of a CT scan. The left column demonstrates baseline pre-Trikafta imaging. The middle column is after 6 months, and the right column is after 2 years. So there was continued improvement in sinus CT scan opacification. This is just one person, but then if we zoom out and look at the data for the whole cohort, there was a continued improvement. So these are spaghetti plots with each individual study participant represented as a colored line. The black line is the mean with error bars. And so the first 2 graphs, quantitative sinus CT score and Lund-Mackay sinus CT score, are 2 ways of analyzing sinus CT opacification. The next 2 graphs look at SNOT-22 score and health utility value for sinonasal quality of life and overall quality of life. And so those both improved in a clinically relevant manner. And then one example of productivity loss is shown where that also improved over time. So continued improvements through 2 years in these outcomes, which is exciting. This is the data shown numerically, which I will skip for now. So in summary, so our study was just one study, and I commend Dr. Stone and his collaborators for publishing this excellent review article in September in JCF. So our study was one of 10 studies that looked at the impact of ETI on the impact of ETI on sinusitis. People these studies use different outcomes. So most studies use sinonasal symptom questionnaires like the SNOT score. Several use CT scans and MRI, and one study used nasal endoscopy. Some of the studies use more than one outcome measure, such as ours, which is why there's more than 10 when you sum all those. So in general, the results are pretty consistent. There's a substantial improvement in sinus disease with ETI for the whole cohort. But I think it's important to recognize that in really none of the studies did ETI fully resolve sinus disease. So it improves it in a clinically relevant manner, but it doesn't totally cure it. And ETI also doesn't work for everyone. So this is an example of an individual who has CF. It's an adult who is on Trikafta and has been on Trikafta for a year. And this is a right nasal endoscopy. So I'm suctioning the maxillary sinus. This person's already had sinus surgery, and he clearly has regrowth of significant polyps. So those are nasal polyps filling the ethmoid and sort of all throughout. So despite Trikafta, for this person, unfortunately, he has ongoing upper airway disease. So there's more work to be done. All right, so I'm going to change gears a little bit. How common is olfactory loss or loss of sense of smell in people with CF? Turns out it's pretty common. So sinusitis is the leading cause of olfactory loss in non-elderly individuals across the world. And the majority of adults or people with CF have some degree of loss of smell. Most of the time, this is a partial loss of smell, which we term hyposmia. Less commonly, this is anosmia or total loss. And again, most of these data are in adults. Loss of smell is less well studied in kids with CF. Sense of smell really matters. I know that a lot of us are enjoying or probably enjoyed a coffee this morning, or perhaps went to dinner with friends or colleagues last night or made tonight. Olfaction is linked to sense of taste or gustatory function, and not being able to smell really can impact our nutrition. It can impact our quality of life, and worse than that, people who have total loss can't perceive noxious odors or rancid smells. And in the general population, loss of smell is actually associated with depression, social isolation, and even increased mortality, which is scary. So what do people with CF think about olfaction? Working to look into this, and I thank you to say a big thanks to the Community Voice team and Jessa, who helped me with this work. We put out a Community Voice survey earlier this year and emailed that out via the Community Voice. And I really am grateful to their team for helping with all this to sort of get a sense of the community's perception of sense of smell. This is data that's currently in submission. So we sent out this survey to sort of ask what they thought about sense of smell, who had smell problems, and would they participate in research. So most people, over 90% of people who responded, had problems with their, reported problems with their ability to smell odors. Most people also were very enthusiastic of the respondents about participating in olfactory research. So the response rate was relatively low, and this might not apply to all people with CF, but for those who are impacted by olfactory loss, this is really a critical issue. Some of the descriptive data is shown there at the bottom. I thought the bottom one was particularly informative. When people self-rate their sense of smell, over half of people who responded to this thought their sense of smell was poor. So for a subset of folks, it's really an important issue. There's different methods to assess olfactory status. As we know, and sort of in the schematic on the top right, the olfactory nerve is the first cranial nerve and sends afferent neurons into the superior nasal cavity, those sort of yellow tentacles coming down there. And then olfactory circuits or olfactory signals are processed superiorly. They move intracranially and are interpreted. So the gold standard way of assessing olfactory function is called a psychophysical test. That's what that booklet on the bottom shows, this sort of scratch and sniff test where one takes a test, tries to identify an odor, and then sends understands it and then reports on that. There are also ways we can evaluate olfactory specific quality of life, and then we can look at radiologic findings. So we can look at inflammation in the superior part of the nasal cavity around the afferent olfactory neurons, and that's been shown to correlate well with olfactory status. So we did this with the same cohort of people that we talked about earlier in the study, and we looked at olfactory function using these sort of 3 measures in the same cohort, of whom 30 people enrolled at baseline, with 28 after 6 months and 26 after 2 years. And what was really surprising, given the major improvements in sinusitis and the known improvements in other areas with highly effective modulator therapy, was that there really wasn't any improvement in olfaction in adults despite being on Trikafta for 2 years. So that held for the radiologic measure, which is the first graph, the symptom measure, which is the second, and then the gold standard, which is shown on the right, the SIT-40 smell test, so quantitative testing. 2 other studies have also looked into this and identified similar findings, that there was no meaningful improvement in olfaction despite Trikafta. And all these studies were done in older adolescents or in adults. So that was surprising to us. So for next steps, we are working on a longer-term study where we'll follow these individuals for an additional 2 years and obtain outcome measures again. We're working with Dr. Vlader on nasal epithelial cell collection and analysis. And then sort of the olfactory findings got us thinking, is it the case, and this was broached earlier by some talks in the session, could it be the case that chronic dysfunction over years or decades becomes irreversible, which is really surprising and is an interesting hypothesis to think about. That then begs the question, could early intervention with any highly effective therapy, be that Trikafta, gene therapy, or something else, limit or even potentially prevent olfactory loss and sinusitis? And so to further look into this, we're working on a study in collaboration with the Begin and Beginning teams to assess sinusitis in young children. So the example at the top is a sinus MRI, which, as we all know, doesn't have ionizing radiation and is safe in young kids, where we're hoping to look at some of these things and see if that hypothesis pans out. And so with that, I wanted to say some summary slides. Multiple studies show that ETI improves sinusitis. There's a clinically meaningful change that persists through 2 years. This improvement occurs across symptoms, CT opacification, and nasal endoscopy. However, ETI does not improve CRS or work for everybody in terms of their sinusitis. And then multiple prospective studies also show that ETI does not improve olfactory loss in adults. Chronic dysfunction, we hypothesize, may be irreversible by the time adulthood arrives, and could early intervention prevent or limit this complication is an area of ongoing study. Thank you so much to all the folks and families who participated, as well as to our whole study team, and especially Dr. Taylor Kauser, who's co-PI of this project, and our whole team here, and all the mentorship and collaborations that exist, without which none of this work would be possible. Thank you for listening, and I'd be happy to take any questions.
Go ahead.
Hi, Vero from MGH. Super naive question. The olfactory data is really interesting. Is CFTR expressed in the olfactory epithelium, or is this more of like a consequence of chronic inflammation leading to olfactory dysfunction?
Great question. CFTR, as you well know, is expressed in the upper airway mucosa, so throughout the sinuses. Some of the olfactory epithelium is actually neuroepithelium, and there's actually limited studies which have been seen because it's tough to sort of biopsy or assess those areas.
Right.
So it's a great question. It's actually an area we've been thinking about in terms of how to better mechanistically look at this. But yeah, it's a great question.
Interesting. Cool. Thanks.
Thanks for the question.
Maybe also a naive question. If I think about olfaction, smelling, you have to learn to smell. You have to, it's a higher brain process to learn this is vanilla and this is coffee and this is whatever. And if you have poor learning input because of a lower functional level of inputs, you never learn to smell. And then you reverse some physiological function, but you don't need to decode it. So you have to relearn to, this is vanilla or this is whatever. And it's a higher problem, a CNS problem.
Completely agree with you. I think that's a great hypothesis. I actually think there's a potential correlate of, and this is just my idea, or not, sorry, this is just me hypothesizing or theorizing along with what you said, but amyloipia, if you're an infant and you can't see, you unfortunately don't develop the neural circuits intracranially or in the central nervous system that permit vision. And no one has thoroughly looked into this to my knowledge, but it's possible a similar process could in fact exist for olfactory circuits. So thank you for the comment.
Well, this is a very naive question, but does CFTR have any role in the development of the sinus cavities to begin with? I mean, are CFTR mutation, individuals with CFTR mutations born already with a handicap that they don't have a fully developed or developable sinus, and that may be why the ETI doesn't.
Also a great question. Thank you. So there are people who have CF have a higher incidence of sinus hypoplasia, so smaller sinuses, or sinus aplasia, absent sinuses, specifically with the frontal and sphenoid sinuses. The last study I mentioned, the pediatric study, is a study that actually assessed, that's one of the secondary analyses. We hope to identify if ETI is associated with sort of structural rescue of sinus morphology over time. So thank you for the great question.
So I have another question related to the potential use of ETI in sinus disease outside of CF. So is there any potential use for it in other populations?
So there is some data that suggests our carrier status, also mentioned as a topic in this session. So carrier status in some studies does predispose to a higher incidence of sinusitis. The UAB group and Brad Woodworth does a lot of work with ivacaftor and CFTR function in individuals who do not have CF but are potential carriers for that. So it's an area of ongoing investigation, and people are thinking about it.
So I'm going to add one more. So I saw your rates of sinus surgery. I don't remember the exact number, but it wasn't super high. And I know some of the work we did with Phys and the registry, there was definitely a dichotomy of centers that were high surgery centers and low surgery centers. This would probably have been a low surgery by the number. One, how do you think that impacts outcomes? And two, methodology-wise, how does that affect the machine learning and the sort of following that progression over time by CT?
If I don't fully, I'll try to answer both parts. If I miss,
No.
so for the second part first, the algorithm is validated in both people who have surgically naive sinuses as well as those who've undergone sinus surgery, which alters some of the bony or thin bony partitions intranasally or in the sinuses. So the algorithm works independent of that, and we've shown that in a cohort and published that, so that it does work. And then remind me on the first part.
So I guess really, is there any difference in your findings based on those that have had surgery versus those that haven't? I guess that's really the crux of it.
With the caveat that our study was not specifically powered to look at that, there is no difference based on prior sinus surgery status for any of the outcome measures.
Where was your machine learning algorithm developed?
National Jewish Health.
Okay. Was that OpenAI? Was that part of the OpenAI project? Or was that...
No, it sort of predated that. Steve Humphreys is the brains behind it. He's an imaging scientist at National Jewish. He's worked a lot with David Lynch, and they have a quantitative imaging lab. It's been around since 2018 or 2019, perhaps even earlier, and we've used it for several years now.
Specifically for pulmonary or respiratory, or is that focused on that, developing that concept?
Most of the work he does, to my knowledge, is actually on chest CT analysis. This was sort of a outgrowth of that.
And I think we can all agree that SNOT 22 is the coolest name of any problem that's out there. Thank you so much.
Thank you for the opportunity to speak.
All right, and then our last speaker is going to be Dr. Matthew Markovitz, who's going to be talking about cervical mucus viscoelastosity and sperm velocity.
All right.
Right, the mouse first.
Yeah. Good morning. Thank you to the organizers for having me, and thank you for everyone in attendance. I promise not to keep you from your lunch too long or to spoil it with talk about mucus. Let's see. Arrow's working? Okay, yeah. I have nothing to disclose, but I'd like to start by acknowledging my collaborators on this project. Everyone on the team at Oregon Health Sciences University has really carried most of the burden of doing the experimental work. So thanks to Chris, Mackenzie, Shuhao, Jeff, and then my primary collaborator, Leo Han, up there, who's an OBGYN, who's really been helpful on this. I'd also like to thank my undergrads, Brooklyn and Camille, for their help with data analysis, collection, and processing at UNC, and the CF Foundation, which provided a pilot and feasibility grant to help do this work. I am a biophysicist primarily, so when I think about CFTR and mucus, I think of them as partners through thick and thin. Yeah, thanks. We've talked about a lot of these organ systems so far, from the sinuses just now. We talked about liver, pancreas, all of this stuff throughout the conference. And then, Gary Cutting in this review talked about the male reproductive tract being affected in CF, but he also forgot that the female reproductive tract is definitely affected as well. When you look overall, the tissues that are affected are mucosal in nature. And that's sort of covered in this review from the Ribbick lab, where you can see these are the primary mucosal epithelial organs, ranging all the way from the sinus down to the reproductive tract. You can see there's a great deal of overlap between the images on the left and the right. And in particular, CFTR dysfunction creates hyperviscous and obstructive mucus in all the organ systems that you see in red. Today, we're going to focus on the reproductive tract, in particular the female reproductive tract. And this has been made clear through several talks and recent papers. Emma also mentioned that there's an increase in pregnancy in women with CF recently. Prior to highly effective modulator therapies, 35% of women were sub or infertile. And you can sort of trace this from a 2015 paper on ivacaftor all the way to a recent review from Raksha Jain, Tracy Kazmierski, and Jen Taylor-Kauser that came out about a month and a half ago that really does kind of outline the state of the art in terms of fertility for women with CF. But this is definitely related to mucus hydration, and hydration is important in endocervical regulation of fertility. You can see in this paper from 1973 tracking the percent solids. So this is basically the percent dry weight of mucus from the endocervix over the course of the menstrual cycle. You can see that it has a clear nadir here during ovulation. So mid-cycle, where ovulation occurs, the mucus has the lowest percent solids. And in an abstract submitted to ATS of all places, Dr. Mike Knowles at UNC submitted that during normal or non-ovulatory phase for women who don't have CF, the percent solids is about 9%, whereas during the ovulatory phase, it's about 2.5%. However, in women with CF, the percent solids is 20% during the non-ovulatory phase, and it's 20% during the ovulatory phase. So it's very clear that women with CF have extremely thick cervical mucus. It's hyperviscous, and it's likely impenetrable to sperm. So we think that this is CFTR related, but how do we study this linkage in detail? And then specifically, we want to ask what cell biology relates hormonal cycles and mucus composition via CFTR. And to do that, a lot of work has been done at Oregon Health Sciences by my colleague Leo to come up with a conditionally reprogrammed endocervical cell culture model from rhesus macaques. They have the National Primate Center up in Portland there, and at NACFC, the female reproductive tract is harvested. Cells are collected from the endocervix. They are conditionally reprogrammed, put on plates. And we know from several experiments done recently that these cells are hormone responsive, they are mucus secreting, and they're CFTR expressing. So speaking of CFTR and ion transport, we know that they express both CFTR and ENaC, and they display very standard features that we're familiar with in the CF community. When you hit these cultures with a milleride blocking ENaC, you see a decrease in the short circuit current. When you treat them with forskolin, you increase chloride secretion, and when you hit them with CFTR inhibitor 172, you see a decrease again in short circuit current. So we know that CFTR and ENaC both are functional in these cells. CREX also express the gel-forming mucin MUC5B, which is the primary mucin in the endocervix as well as in the airways. You can see that this is hormone responsive. So if you hit these cells with estrogen or estrogen and progesterone, you can see that there's a dramatic increase in the amount of MUC5B produced by the cultures. They're also poorly ciliated. So speaking in terms of morphology, they're poorly ciliated, and the luminal mucus is quiescent. And this is important for later, but I just wanted to note that now. Going back to biophysics, which is more in my wheelhouse, coming out of our lab, the Hill lab at UNC, we believe that mucin or mucus concentration is the primary determinant of pulmonary mucus rheology. And in these four model systems at left of pulmonary mucus, whether that's porcine gastric mucin, bovine maxillary mucin, human bronchial epithelial cell culture mucin or mucus from either non-CF or CF cultures, we can see that in the higher concentration case, so in the gray bars, whether it's 5% or 4% solids, the viscosity is increased relative to the low concentration mucus at 2% solids. So in every case, here I'm just highlighting PGM, 5% solids, there's a 10-fold increase in the viscosity of mucus relative to a lower concentration mucus. However, going across the way, we're now changing pH across a physiological range from pH 6 to pH 7 to pH 8. There's no real noticeable change in the viscosity in either high concentration or low concentration mucus. So we believe the primary determinant of mucus rheology, at least in the pulmonary system, is concentration. And at right, you can see that there's this sort of rheological master curve that's displayed in these mucus systems, where in between 0.1 and 1% solids, so dilute mucus systems, not necessarily what you would find in physiology, mucus viscosity is related to concentration at a power of C to the 5. However, as soon as you get above 1% solids, so you're now living in this physiological range, there's this huge dependence on concentration. It's about C to the 4, C to the 5, depending on what system you're in, whether that's endotracheal tube mucus, human bronchial epithelial cell mucus, or even just pure MUC5B. So again, the mucin MUC5B demonstrates this power loss, so we think that that's probably the primary determinant of what's going on. It's concentration, that is. Moving now into the main content of this talk, we have two primary hypotheses that we want to test. The first is that sperm motility or velocity in cervical mucus is a surrogate marker of fertility status. This is still sort of up for debate, but it is used as part of the assessment in the World Health Organization manual, so we're going to run with that. And then the second hypothesis is that particle tracking microbiology, or PTMR, can be used as a surrogate marker of sperm motility, that is, a surrogate marker of fertility status. But first, we need to show that PTMR correlates with sperm motility. So the first question that we ask is, like in the airways, is cervical mucus rheology concentration dependent? The short answer is yes, but if you're not a biophysicist, you've probably never seen plots like this. So we'll start in the undiluted mucus case. So this is mucus that is harvested from rhesus macaques. That we've done 5 total macaques. This is only one representative data set, though. So when you start with undiluted mucus, you can see that the viscosity, which is on the x-axis, is very high here. It tends to be relatively homogeneous. There's a smaller dilute component to this as well. But as you begin to dilute the mucus, you see that there's a rapid swelling component, as well as a more stable solid-like component. And this continues as you dilute the mucus further down. Once you get to 1 to 8, it begins rehomogenizing again. 1 to 16, it's even more homogeneous. And then as you get to incredibly dilute concentrations, you settle in nicely at the theoretical sort of prediction for a dilute polymer system, which is 2 times the viscosity of water. And over here, the control is Heapy's buffer, which has the viscosity of water, which is that dashed black line that's vertical there. So we then ask the question, is sperm velocity concentration dependent? One thing that we struggled with early on is that computer-assisted sperm analysis, or CASA cassettes, are too narrow for loading viscous mucus samples. So you try to pipette the mucus into the CASA cassettes, and it just kind of squeezes back out because it's so viscous. So one aspect of innovation that we have in this project is that we're able to actually load sperm into mucus and then put it on a slide and sandwich it there, which is the same sort of experimental system that we use for PTMR. So exact same experimental conditions, exact same microscope, exact same video camera that we use to record sperm motion is what we use to record the bead motion that reports the viscosity. So you can see in this video here, sperm are moving around, and we're able to track them. So there's a little bit of innovation there, but we made it work. So we'll move forward. We'll assess sperm motion. Again, this is that same data set from the same 5 rhesus macaques. In whole mucus, you can see these are the sperm trajectories. There's a number of sperm that just don't move at all. This sperm did not move very far. As you begin to dilute, the tracts begin to elongate. You can start to see as they elongate, the clear head shakes as the sperm wobbles back and forth in its precession, and that continues out as you dilute. But the quantification of that shows clearly that there is a concentration dependence on sperm velocity in terms of mucus concentration. So as you decrease mucus concentration, you increase sperm velocity, and you actually increase sperm velocity to above that of what they display in a non-viscous media, which is an interesting phenomenon known for microscopic swimmers, that within the presence of even dilute polymer systems, swimmers move faster than they do in a purely viscid medium. Overall, though, putting these two data sets together, we see that sperm velocity is in fact dependent on mucus viscosity. It's a pretty clear correlation where as you increase viscosity, you decrease the sperm velocity. So we think from this data that we've shown that viscoelasticity is a possible surrogate measure for sperm velocity or penetrance. One, it's a lot more convenient to deal with beads than it is sperm, but also it's nice because it's a possible benchtop marker of cervical mucus fertility status, which we greatly lack in the field. But bringing it back to ion transports and CFTR, as the topic of the session would require, first we'll look at ENaC. Actually, we'll look at a Milleride response. So here now viscosity is on the y-axis, and you can see there may be a dose dependency at 48 hours, but after you treat with a Milleride, you ablate sodium absorption over time, and you can see that the viscosity is decreased in the high dose of a Milleride relative to the control. And we think that this is due to hydration because we've adapted a methodology from my former mentor at University of Pittsburgh, Mike Meyerberg, where we're actually looking at the hydration status of the cultures over time. This is sort of an inverted graph where the downward trend is how much they've dehydrated, because we've added a bolus to start the experiment, a liquid bolus to start the experiment, and the further down it goes, the more liquid has been absorbed. You can see every time that we add a Milleride, you increase the relative hydration over time, and the effect only becomes more substantial. When we look at CFTR, the good news is that we get the exact opposite response. So if you inhibit CFTR with BPO27, you can see at day 1, there seems to be a trend, but these are relatively thin. We've added a big bolus of water, so there's not very much viscosity to measure. However, at day 3, there's a very clear 4-fold increase in the viscosity of the mucus on these cultures. And I forgot to mention, this is done in situ, and that's why it's important that the culture system is quiescent. You couldn't do this in HBE cell cultures because the cilia would move the beads all around, and you couldn't actually measure their diffusion. But again, this is related to air surface liquid hydration. So using that same sort of measurement, you can see in the control is always more hydrated than the inhibited samples. So we think that by ablating chloride secretion or just anion secretion in general through CFTR, you can induce a dehydrative phenotype in these cells. To summarize, CFTR plays a critical role in modulating the fertility status of cervical mucus, and that is done via hydration. Mucus hydration governs the viscoelasticity of mucus and therefore sperm penetrance. PTMR can also be used as a surrogate for sperm penetrability, which we think we're going to try to use this assay going forward in a lot of ways. We've also developed an in situ culture-based assay of mucus hydration and viscoelasticity, and so in the future we hope that our assay can be used to identify non-hormonal compounds that may utilize CFTR and other ion channels as contraceptive targets. But then relating to CF, we hope to identify targets that can improve fertility, including in women with CF who are not eligible for or are unable to tolerate highly effective modulator therapies but still may want biological children. With that, I'd like to thank everyone in the Hill Lab who's been so helpful. Again, thank my colleagues at OHSU. Thank Camille Ayer for her help in getting some of these cell culture systems started, and then Rick Boucher and Michael Knowles for some consultation that they did on this topic. I'll take any questions.
So I'll start off then. And this is a very I expect a speculative answer, but for the data describing increase in birth rates among women who now are on ETI, is that due to changes in their cervical mucus, or what is the overwhelming thought in the field of why there's an increase?
Yeah, so that's a really interesting question. Andrea Rowe had a symposium talk yesterday that sort of mentioned that using the traditional Insler score method of assessing cervical mucus status, there were no differences in terms of cervical mucus status in women on highly effective modulators, but there's really never been much. It's like a qualitative test. It's a qualitative test, and it's never really shown much efficacy in terms of actually demonstrating outcome. So we think that by actually doing a quantitative biophysical assay, maybe we're going to show something, but it is very speculative. Obviously, interest in having a family now has increased as well due to improved health and lifespan. So there's a lot of variables to parse out.
All right, well, I guess that's going to be it, guys. Thank you to all of our speakers. I had a really fun time session. Thank you, everybody, for being here on a Saturday morning.